Hello, everyone. Welcome to another session with me, Raheel, Shariff, and I've got my colleague Amer Shoaib with me. Hi, Amer. Welcome.
Hi, Raheel. How are you?
I'm good, thanks. How are you doing?
Yeah, very good. Thanks. I'm really looking forward to this.
Absolutely. So we're going to be discussing all things Lisfranc for the next hour and a bit. We're going to start off with the usual. We're going to have a case. We're going to discuss a case to see where we are at. And then Amer is going to give us a talk on Lisfranc injuries. I'm quite looking forward to it because he's got a large amount of experience. Do we fix? Do we fuse? Do we leave them alone? All things to do with this fairly rare injury, but one which is missed quite often. So let's start off with a case. Amer, so we've got, let me just switch, sorry, give me one moment, this one, yeah. So we've got a 21-year-old lady who's fallen off a trampoline and she can't bear weight. She's got swelling in her foot. And this is the x-ray we see. Amer, what's the most important pathognomic sign clinically we're looking at for a Lisfranc?
Well, if I see a swollen foot, to be honest, the first thing that goes through my mind is, has this patient had a midfoot injury? Is there a Lisfranc? So a swollen foot, and I'd be looking for bruising. And if there's any bruising on the medial side on the plantar surface, then that's it. I'm sold. That's, you know, there's I'm very, very suspicious of a Lisfranc, yeah, until proven otherwise.
Absolutely. Okay. So you've got this lady. She's fallen off a trampoline and she's come into the ER. Initial steps, Amer: analgesia, assessing for bruising, and then what are you going to do?
Well, you know, as you say, analgesia. So, you know, she's got an injury. It's painful. So I'd put them into a back slab, give them analgesia, do the usual medical history, make sure that there aren't any other injuries as well. Because although she's fallen on a trampoline, we don't really know any more about the mechanism yet. So, if you're falling off a trampoline, I'd probably go through the whole lot of the ATLS thing as well, just to ensure that it's an isolated injury.
So let's just focus on this X-ray for a bit. Anything suspicious that you see?
Well, I'm going to be looking at the alignments, and already I can see that the second metatarsal doesn't line up with the intermediate cuneiform, and the fourth, you know, doesn't line up too badly with the medial side of the cuboid. But if you look at the third tarsometatarsal joint, you can see it's really grossly shifted. So I think that pretty much confirms to me that, you know, she's got a Lisfranc injury. And
so this is an oblique of the foot, right? And on an oblique, if you just want to tell our audience quickly what are the lines we're looking at.
So on oblique, really you're looking at the medial side of the fourth metatarsal lining up with the medial border of the cuboid.
And the medial of the third lining up with the medial of the lateral cuneiform, correct?
Yes, yes.
And here there seems to be a bit of a mismatch on that third TMT joint. Okay, so let's see. This is your CT scan. There are no apparent fractures. So in effect, there seems to be a soft tissue injury. Now, the question we have, and we'd like the audience to answer, is a bony Lisfranc a ligamentous injury versus a bony injury? What's the prognosis? Is it your option is worse than a bony injury? Is it better than a bony injury, or is it the same as a bony injury? So we're going to give our audience a moment to take that in and answer that question on the poll that's being pushed. For those of you who haven't attended before, through the course of this session, we're going to be pushing polls to you. We'd like you to take part and answer. They're completely anonymized, so don't worry if you're getting them right or wrong. We will be also pushing handouts to you, possibly some important seminal papers, and it's going to be fairly interactive. We'd like you to ask questions in the chat box, and as we go along, as you ask questions, we will be taking it to the speaker. Okay, so Amer, we've had interesting. 100% of the audience says that a ligamentous injury is worse than a bony injury. Would you dare to be different, Amer? Or do you agree with the audience?
No, I think we've obviously got a very well-informed audience because with a bone injury, you can expect bone-to-bone healing. With ligamentous injuries, usually you've got little fine avulsions, but the prognosis is actually worse, and you need to be perhaps a little bit more aggressive. So yeah, I agree with the audience.
Okay. So moving on. Here is another question for you, Amer, and for the audience. A ligamentous injury can be treated by, let me just get this up for the audience. Great. Open reduction and bridge plating for 3 months with non-weight bearing. Okay, so these are our options. ORIF and fusion with screws, transarticular screws for 6 weeks non-weight bearing. ORIF and bridging with staples and 3 months non-weight bearing. ORIF and fusion with staples, 6 weeks non-weight bearing, or it depends on the patient's circumstances. So we've got a whole host of things. We've got screws through the joint. We've got bridging, the concept of bridging, where we're not touching the joint, we're just realigning the joint and placing a neutralization device, either a staple or a screw. Or we've got fusion with staples, or depends on the patient's circumstances. So what do you tend to do, Amer? Do you tend to use screws in your practice?
I don't actually. I tend to use staples, even for fusions, or even if I'm bridging, I'll just use the same implant. So I just tend to use staples.
So you tend to use
but
staples.
there are some very nice plates on the market now. So it's horses for courses. Whatever works best in your hands, and it's really a question of decision making rather than the implants that you're going to use, I think.
So you use staple. I tend to use plates. Neither of us tends to use screws. So as we go through this session, we're going to discuss the pros and cons of each of these implants. At the end of the day, the most important prognostic factor for your outcome is your alignment. We all agree with that. So let's see what the audience seems to think. It's fairly divided. Wow, that's a completely equal split through the 5 options. So it just goes to show it reflects practice in different parts of the world and different parts of Europe as well, isn't it? We've got people opting for bridge plating, screws. So what we do know is there is no definite right or wrong. Through the course of this talk, I'm sure Amer is going to try to highlight the elegance of bridging as opposed to using transarticular screws if you're going to fix a fracture. For fusion, your device of choice is completely in your hands. So which of these would you go for, Amer? Which option would you go for?
I'm going to go with depends on the patient's circumstances. And the reason is that if you've got somebody who doesn't have good balance, and they're going to find it difficult to remain non-weight bearing, then you want them to be non-weight bearing for as short a period as possible. And for that reason, I'd be thinking about fusion rather than fixing in situ, because fixing in situ means that you've got to keep them non-weight bearing for 3 months. And that's a big ask for a lot of people who are working. That might sway them to say, well, I don't really want to spend 3 months non-weight bearing. I'd rather spend 6 weeks non-weight bearing and then try and get back to work.
So just to clarify, if you fuse someone, you're going to keep them non-weight bearing for how long?
For 6 weeks.
And if you fix someone,
if I'm fixing them, then I'm going to be waiting for 3 months.
Okay, so that's quite different to what I tend to do. Whether I fix or I fuse, I keep them non-weight bearing for 6 weeks. Now I know it's horses for courses, but the advantage of probably considering fusion as a primary means, your thoughts on this before we delve into the talk itself?
Okay, fusion,
so if there is a fracture, whether it's comminuted or not, what is the advantage of fusing primarily versus fixing?
Well, the advantage of fusing is that the reoperation rate is a lot lower. And it also means that they can weight bear with less pain earlier on. There is a reason why I put, why I'm considering 3 months, and the reason I'm considering that is because there's evidence about the the time that it takes for soft tissues to heal, to give you enough stability. Because if you get somebody weight bearing at 6 weeks, there is a risk that their soft tissues, the scar tissue, hasn't matured enough, and it means that you might get failure. So that's why I'm a bit more conservative with the people who are being fixed. But that's one of my main sort of decision makers. You know, what the patient wants and what their social circumstances are. You know, as well as other factors like how common used it is. You know, whether it's ligamentous or bony, and the degree of displacement. Okay. So there are lots of factors, but I think I'd weigh all of those up, and I wouldn't plump for any one of these unless the patient had been sold on that and they were convinced that it was the appropriate choice for them.
Okay, so let's see what I've done for this patient. Okay. Lo and behold, so we've gone with bridging with staples, which is a perfectly reasonable way of fixing this. I'm quite curious. You've got that tightrope there between the medial cuneiform and the base of the second metatarsal. Yeah. So that's obviously you've used that to try to bring that ligament back into congruity and stabilize it. So just talk us through your. I'm not even going to talk about that screw in the lateral column just yet.
Let me tell you.
You were having a brain freeze.
I was hoping you weren't going to mention that. I hope you weren't going to mention the screw, because that is a mistake.
Okay. So do you want to just highlight to our audience why? Let's talk about the tightrope. Okay. So your sequence of how you go about fixing these before we look at that lateral column and discuss the screw. So how do you go about doing this? What are your principles of approaching a Lisfranc?
Right. So this is a ligamentous Lisfranc, and the patient's obviously gone for fixation rather than fusion. So there's one stable across the first tarsal-metatarsal joint.
So is that your first step?
The second. It's not. The first step is basically the open reduction. So I reduce the second, do an open reduction, and then I would just put a K-wire in as a temporary fixation measure. And then after that, I would use other elements like the staples across the second and the third to keep them reduced in the ideal position.
Amer, just to clarify for myself and for the audience, your approach in this is going to be a dorsal approach between your first and second? Okay, great. That's your first step. And you tell me you reduce your second metatarsal back into its recess.
That's right. So there's a little mortise, because the second metatarsal goes more proximal than the first and the third. So it sits in its little recess, and we can see the reduction onto the intermediate cuneiform. So I'd get a temporary fix with some K-wires, and then I'd put my definitive fix in with some memory staples, and then we need to reconstruct the Lisfranc ligament, because once the ligament is gone, it's gone forever. You know, they don't heal up. So we're relying on scar tissue to hold everything together. So it's nice to put in a tightrope. And there's a part of the second which is non-articular, because there's no ligament between the first metatarsal and the second metatarsal. So there's a bare area which is non-articular on the second and also on the medial cuneiform. So we can get the tightrope across there, and that will reconstruct the interosseous Lisfranc ligament. And then the medial, I'd use the medial approach to put a memory staple. And if I'm fixing, I'm not going to go down and strip all the periosteum off. I'm just going to put the staple in to hold it in an anatomical position. And what I should have done for this on the fifth side, on the fifth ray, is use a K-wire rather than a screw.
So let's just say that you scrubbed out early and your registrar went crazy. Yeah.
It'd be nice to blame someone else.
Yes. Yeah. Okay. So what we're trying to allude to is it's not a good idea to stabilize your lateral column, which is the fourth and fifth tarsal-metatarsal joint. You almost hardly ever use fixation. And I can see from your slide here that you actually removed that screw within 6 weeks, which is perfectly fine if you've decided to stabilize it. So it's probably, we tend to use KYs, and I know you do as well. It's one of those rare occasions where a screw is used, but it's a point to be highlighted to all of us that screw fixation of the fourth and fifth tarsometatarsal joints never is a good idea in fixation of in the foot. Okay, so let's move on. So this is 3 months after commencing weight bearing. This is the appearance on the x-rays. So the course of action now is, let's give the audience a chance to see what they would do. Remove the metal, assess the symptoms, replace the metalwork, or stress x-rays. So what do we see on that x-ray?
So what we can see is that the second metatarsal is really nicely lined up with the intermediate cuneiform. On the oblique, the third looks like it's really nicely lined up with the lateral cuneiform, and the fourth looks lined up nicely with the cuboid bone. So in terms of alignment, I'm pretty happy. But these memory staples are broken, and they're broken because they have fatigued, because there has been some movement at those joints, and that's normal. It's natural to have movement at those joints. And it looks like the audience have decided that they're not going to dive in and remove the metalwork and subject the patient to another operation. They're all of them going to assess the symptoms. And I would agree with that, because if you've got broken metalwork, that doesn't mean it's a problem. These are fairly low profile implants, and if they're not palpable and they're not causing any symptoms, then I would just leave them inside the patient. And what they demonstrate is that there is some movement at these joints, and in a normal foot there is a little bit of movement at each of these joints, perhaps more so in the first ray than the second and third, but it's normal to have these this degree of movement, and that signifies that the function may be fairly normal as well.
Okay, great. So I think we all agree with what the audience is saying here. We're going to assess the symptoms, and it's probably not wise to remove metalwork unless we absolutely have to. I've got a question before we dive into your talk, Amer. Now, there is with staples, there is an argument, because these are compression staples, these are nitinol staples. Correct me if I'm wrong, right?
These are memory staples.
Memory staples,
so
yeah.
Essentially, they are there are two types. You can get ones that are temperature dependent. So if you keep them in the freezer, they stay straight, and when you put them into the body, when they heat up, they're made out of two different types of metal, and they start to compress. And it's a dynamic compression; they're always compressing. And the preformed staples, which come bent, and you have to unbend them when you insert them into the patient, and so when you put them inside, they start exerting pressure again, and again they're dynamic.
So I'm a proponent of bridge plating, so I'm going to play devil's advocate here. Okay, the argument for not using staples, where I come from, is that staples actually compress. So in effect, if this is your sagittal foot with your TMTs here, you're essentially going to increase the cavus in that foot by causing compression. No matter how much you try not to, you end up with that. Your thoughts on this? Because I know you're a big proponent of bridging with staples.
So that's not something that actually happens. There are lots of things that we worry about, but it's not something that actually happens. So we don't. If you look at those joints, you can see that they're actually perfectly parallel. And it's maintaining the position, so it's almost like a fixation device rather than a compression device. And because the leg goes out of the cortex on the plantar surface, it gives equal compression throughout the whole of the staple. And that's why it's important that you have a staple which is long enough. There are lots of manufacturers whose staples are only about 20 millimeters long at the longest, and unfortunately, because the TMT joints can be 25 millimeters long, it means that you may then generate pressure within the bone, or you're compressing just the dorsal surface. But I want to be able to compress the whole of the joint evenly.
So in your experience, you've not had that problem?
No.
Okay.
And when the when you get breakage of the staples, they're not prominent. And one of the commonest reasons that people have reoperations when they have plates put in is because of prominent metalwork, especially if they're broken. Okay. So I'm very keen on staples because even if they break, I can just leave them in situ.
Great. So that's just a bit of an appetizer for the talk Amer is going to give us now. And without further ado, Amer, over to you.
Okay, thanks very much, Raheel. So what we're going to talk about is Lisfranc injuries, basically starting at the beginning and going through all the controversial areas. So first of all, we should really start by talking about what a Lisfranc injury is, because there are lots of different variants. And then we're going to talk about the anatomy and the mechanics, have a little think about the pathomechanics, and then we'll talk about those important clinical findings that will make you more concerned that there may be a potential Lisfranc. How are you going to go about investigating it? And then let's talk through the evidence about what decisions you're going to make and how you're going to tailor your treatment for each individual patient. And I thought it would be useful to talk about the operative techniques as well. So let's start off though by having a poll. So this is an injury which is quite commonly missed. You've said that before, Raheel, but how common are these injuries missed?
Okay, so we've got options here. I would say at least a third of injuries tend to get missed, particularly in the emergency room, in the accident and emergency, and even surprisingly in fracture clinics. Let's see what the audience, 25% is what the majority of the audience seems to be going with. Why, Amer, so whilst we're getting these answers, why do you think it's such a commonly missed injury?
Basically because the x-rays can look surprisingly normal. Now, if you look at that x-ray that is on the screen at the moment, if you look at all the alignment, actually it looks fine. But there are some really subtle signs there that there is an injury. And quite often we're focused on looking at the x-ray, trying to find something. And sometimes it's actually better to look at the patient's foot. So if you look at the patient's foot and it's swollen like a balloon, then it's a Lisfranc injury until proven otherwise. And if you see the bruising underneath, then I would actually ignore all the normal investigations and I'd keep investigating them until I've proven that it was a Lisfranc injury. And unfortunately, at the moment, people are in a rush, and especially in the emergency department, they might just look at the x-ray, see that it looks fairly normal, and just reassure the patient, tell them it's a sprain, and move on. And I think that that's something that really hasn't changed over the last 15, 20 years.
Yeah. Okay, so the vast majority, over 50% of our audience goes with 25%. Enlighten us.
Yeah, I'd agree, absolutely, 25%. Let's talk a little bit about what a Lisfranc injury is. Well, a Lisfranc injury is basically it encompasses fractures, subluxations, and dislocations involving the tarsometatarsal joints of the foot. And because they're so frequently missed at first presentation and they're not diagnosed, it means that in our line of work, it leads to a lot of chronic foot pain and disability that patients may turn up to our clinics weeks or months later, or even years later. Now, 25% is a rough estimate, but it's about that. And if you consider that it's 0.4% of all fractures, that's about 1 in 50,000 of the population. But we can't really be sure of the incidence because actually a lot of them are being missed. So it might actually be that the incidence is far higher than what we think it is. Now, Lisfranc is named for a French surgeon and gynecologist called Jacques Lisfranc de Saint-Martin, and he, interestingly, was a very young doctor, I think only 24, who served in the latter end of the Napoleonic Wars in 1814, and he described a amputation through the tarsometatarsal joints, and we commonly associate it with the injury of falling off a horse and the foot being caught in the stirrup, but that's not the reason that it was called. It wasn't him that described that. What he described was the amputation, basically because of the soldiers getting trench foot. But the line of joints, the tarsometatarsal joints, and the ligament between the second metatarsal and the medial cuneiform is named after him. So in the foot, let's start off with the mechanics. There are 3 functional columns, and I think that's it's important to think about these. So on the medial side, you've got the navicular, the medial cuneiform, and the first metatarsal, and that's quite a mobile ray. You know, if you manipulate your own great toe, you can feel that that ray moves quite a lot, and that forms the medial longitudinal arch, one of the 3 arches in the foot. Then there's a middle column, and that middle column is a lot less flexible. In most people, you only get a few degrees of movement, and that column involves the navicular, the intermediate and lateral cuneiform, and the second and third metatarsals. And then you've got a lateral ray, which is the cuboid and the 4th and 5th metatarsals, and that is again a very mobile arch with lots of movement at the tarsometatarsal joint. So you've got these 3 different columns with each with its own characteristics. And then if you look at it another way, you can look at the 3 arches. There's a medial longitudinal arch, the lateral longitudinal arch that we've talked about, but there's also a transverse arch, and this is what's known as a Roman arch. And it's quite interesting that in architecture, you've got a Roman arch which has got a keystone in the middle, and the foot has exactly the same kind of structure with the intermediate cuneiform sitting behind the second metatarsal, forming that keystone function. Now, the arches are segmented levers, and it's not just the arches, not the bony anatomy that gives you those arches. Of course, there's soft tissues, there's lots of plantar ligaments, there's the plantar fascia, and you've got long flexors as well. And that gives the foot a very dynamic function. So when it hits the ground, it absorbs shock. It could also stores that energy, and can be like a springboard to push the foot upwards again. It distributes the weight evenly over the sole of the foot. And because of these arches, the neurovascular structures can run underneath and not be compressed. So lots of different functions in the arches of the foot. Now, if you look at the foot, the second tarsometatarsal joint is recessed. So it sits behind and it forms a little mortise joint. And there are no connections between, ligamentous connections between the first metatarsal and the second metatarsal. So actually the ligamentous connections between the second metatarsal and the first ray are between the medial cuneiform and the second metatarsal. And there are 3 ligaments. There's a dorsal, an interosseous, and a plantar ligament. And it's the interosseous one, the Lisfranc ligament, that's the one where all the strength is. And unfortunately, that's the one that is sort of destined to be injured in a Lisfranc injury.
So, Amer, I've got a question there. If you just flip back to a slide. So the interosseous ligament in the plantar Lisfranc is the most important, correct? Now, let's imagine this is your medial cuneiform and your intermediate cuneiform, and they're together. When your Lisfranc ligament is injured, often we have to look at our CT scan, the axial cuts, and we tend to see a bit of divergence between these 2, right? The cuneiforms.
Yes.
How do you address that in your surgical correction? That divergence. Do you tend to put a clamp across them, bring them together, and put a... Because I don't see you use too many home run screws when you're bridge plating.
what I'm tending to do is use a tightrope to connect those two together.
Okay.
And that essentially for me is it's reconstructing the interosseous ligament, which is
so
one that's going to give them congruence.
So a tightrope is almost a given in most cases of fixation for you. Is that correct?
That's right, yeah.
So that's acting like your home run. Okay.
Okay. So if you think about the tarsometatarsal joints and the forces that might be causing the injury, there can be direct injuries, which means that the force is acting directly onto the foot. And if it hits the metatarsal, it might push the metatarsal down and leave a fragment of bone which is connected to the dorsal side of the cuneiform row. Or if it hits the cuneiform row, that will push that downwards, and you'll end up with the distal segment being on the dorsal side, and perhaps an avulsion on the plantar surface of that distal element. And then also there's the indirect way of injuring the foot, and this is the way that the foot is injured when you fall off a horse and your foot's caught in the stirrup. But there are lots of gymnasts or in sport where the foot's in that kind of precarious position with maximum sort of plantar flexion, and you're putting all your weight on the metatarsal heads. It is possible to then damage the ligament structures, but with an indirect force. So it's much lower energy, and it's even quite well described with people sitting on the toilet with their feet plantar flex touching the ground, and perhaps if they're a little bit overweight and they just fall forwards a little bit, they can end up with that indirect force causing a Lisfranc injury. So although we associate it with a high energy type force.
Does that commonly happen? Does that happen often?
It does.
Okay.
It does, yes. So it's not necessarily a high energy injury. Yeah. And maybe this is why when people give a story of very little trauma going to casualty, it's just assumed that it's a sprain rather than a serious midfoot injury, which is what a Lisfranc injury is. So clinical findings, they really do vary. But first of all, you've got a history of an injury. The patient finds it difficult to weight bear because of the pain, and what we often see is a lot of swelling. So this is quite an extreme example where there's almost sort of delamination of the skin because of the amount of swelling. But it's not uncommon for people to come in with their foot swollen like a balloon. And if you see that, even if the x-rays look normal, if you see a foot that's swollen like a balloon, that should really set the alarm bells ringing. And if you look on examination, if you see that ecchymosis on the plantar surface, especially on the medial side, again, you should be really suspicious that this is a Lisfranc injury, and you don't want to be one of that 25% who's missed that injury.
So just because we discussed this in one of our previous webinars on compartment syndrome, you believe in decompressing the foot when there is possible evidence of compartment syndrome. So in that case, going back, how would you? It depends on the circumstances.
So if there's a fracture or dislocation that I'm going to need to put metalwork in, and it's in the vicinity of where the incisions are going to be, then I would shy away from decompressing them, because I know that I've got to put metalwork to stabilize those joints. If the fracture is not in the surgical field, then I'm quite happy to decompress compartment syndrome in the foot. Okay. So when we get x-rays, quite often in emergency departments, they only give you two views. They give you an AP and they give you an oblique. But it's absolutely essential to get three views, because it might be that third view where you can actually see that there's something going on. So on the AP, the top picture there, you can see that we're looking to see that the medial side of the second metatarsal lines up with the medial side of the intermediate cuneiform. And if they don't, then that's a Lisfranc injury. If you see more than a few millimeters of a gap between the first and second, admittedly, there's no ligamentous connection between the two. But if you see more of a gap, then it's probably because the ligament has gone. And again, you should be suspicious. In the middle X-ray, you can see the fourth ray, the medial side of the fourth ray should line up with the medial side of the cuboid. And if it doesn't, then you've got to be concerned that there might be some shift of the fourth ray going laterally. And if you look on the lateral X-ray, you want to see a nice smooth line between the cuneiforms and the metatarsals. And if there isn't, then of course that means that there's a Lisfranc injury. Now, there is this sign on the flex sign, and this was actually the pole that we looked at early on in the talk. That little flex sign really means that a little bit of bone has been pulled off with the ligaments. So if you see the flex sign, again, that should set the alarm bells ringing. This is a Lisfranc injury. I've got to take it seriously. I've got to investigate it to decide, does it need to be treated more seriously, and is this patient going to need surgical reduction?
So in clinical practice, we get X-rays as our time. How much do you rely on X-rays as opposed to, because these need to be weight-bearing X-rays, and patients are quite painful when we're trying to get them to weight bear for these. So how much are we relying on X-rays as opposed to CTs and MRs? What's your practice? Do you tend to prefer CTs or MRs?
I pretty much CT everybody.
Absolutely, I agree.
And because even when we call something a ligamentous injury, usually it's there are little avulsion fractures at the margins of a joint, and that gives us the clue that it is a ligamentous avulsion.
Or the diastasis between the cuneiforms.
Absolutely. But I think, you know, you need to start off with plain X-rays as a screening measure. But if the foot is really swollen, no matter what the X-rays show, I'm going to be getting a CT scan.
Weight-bearing CTs? Because we've been using it in our practice, and it's really changing the way we're looking at things. We've started using it in fractures as well. It comes into its own with flat feet, but no role for weight-bearing CTs in acute trauma. I
think when especially in trauma, when the patient's in a lot of pain, you're going to find it very difficult to get them to put all their weight through that, and it might actually be misleading that you think you've got a weight-bearing CT or X-ray, but it isn't, because the patient's in too much pain to comply.
So we've got a question from the audience. What about weight-bearing X-rays? Sure. We've just discussed this. Do you ever ask your patients to bite the bullet for 10 seconds and weight bear, because it'll give you a lot more information? Because that's a school of thought which
I absolutely agree. There is a role for the weight-bearing X-ray, and that's for somebody who has a normal X-ray, but you're clinically very suspicious that they may have a Lisfranc injury. And what a weight-bearing X-ray, a true weight-bearing X-ray, will tell you is whether there's any divergence. And if there's a diastasis, then you know that you have to treat them operatively. If there's no diastasis, then the likelihood is that they may just have a sprain rather than actually rupturing their ligaments. And there may be a role for a trial of conservative treatment, but I would still be watching them like a hawk. I'd want them to come back again and get another stress X-ray just to make sure that I haven't missed something. So I would definitely get a CT scan for, pretty much every patient with a Lisfranc injury. And sometimes you can be surprised, because the plain X-rays for this particular injury, we're going to see this injury again a little bit later when we discuss the case. The plain X-rays didn't really indicate how bad this was. That the whole of the medial cuneiform has actually been subluxed, but the CT was able to demonstrate this really nicely. So if you've got a patient whose foot is still very swollen, they've got that pathognomic ecchymosis and you've got normal x-rays, then you've got to carry on investigating the patient. And that means getting a CT, and an MR scan may show you that there's some high signal around the Lisfranc ligament to show that it's been damaged, and some bone bruising within the cuneiforms and the metatarsals to indicate that it's more of a more serious an injury than the plain x-rays may suggest. And as you know, that person who asked that question asked, yes, we would get stress x-rays, and I'd have a very low threshold for doing stress x-rays or even doing an EUA if I was very suspicious that the patient had a Lisfranc injury, but they had normal x-rays.
So that's really interesting, Amer, because in my practice, I almost have no role for stress x-rays. Just so that we can discuss this for the benefit of the audience. I tend to stress all my Lisfrancs intraoperatively to see the stability of the medial column, because if it's unstable, even if it all lines up great, I'll stabilize it with bridge plating. But I tend not to use stress x-rays as a diagnostic tool. So I'm curious to get your thoughts on how you use that in your practice.
Essentially, it's when clinically I'm convinced that they've got an injury and the investigations don't seem to confirm that. So if you had a true pure ligamentous injury and the CT just suggests that everything was sitting in the right place and there was no indication of any fractures, then if the foot was really swollen, I'd still be so suspicious that I'd say, no, I've got to do something else that's going to give me some dynamic information about the stability of these joints, and that's where a stress x-ray would be helpful.
But in the vast majority, we are able to pick up on x-rays and a CT, correct? So this is that small minority in which
it's a very small number where I'm convinced in my head and I'm trying to prove myself right that there is an injury. And it's a precursor to then going in and stabilizing it. But if I performed a stress x-ray under an EUA, nothing moved, then I just have to say, actually, it's stable, it's probably just a sprain, and this patient can be treated conservatively. So that's the investigations, and then classifications. Now, in orthopedics, we love a good classification. This is from Cranial and Cuss from 1909, and the reason I like this is just because it has survived so long, and it's a very narrative classification. It just describes which way the bones have gone, and in many ways you could say, well, it's not really that helpful in terms of deciding your management, but every other subsequent classification has been a minor modification of this particular classification. Even sort of Raheel's worked for Mark Meyerson.
I'm gutted you haven't used the Meyerson classification.
And the Meyerson classification really isn't that much different from Cranial and Cuss. So it stood the test of time. And they talk about injuries being homolateral, where you basically disrupt everything going in one direction, or you can have a partial injury where either the first ray or the lesser rays are going in, one of them is stable and the other is moving, or you can have the divergent where the first ray moves in the opposite direction to the lesser rays, but all of them are injured. But in my mind, decision making depends on so much more than just what the X-ray looks like and what the CT looks like. There are patient factors that we have to consider. So let's talk about decision making, because there are issues that still are controversial, and I think we should go through them one by one and try to iron out what the evidence says about each, and about what we should be doing for our patients to give them the best possible result in the future. So, should we operate on patients at all, especially if they're undisplaced? Could we say an undisplaced Lisfranc injury needs to be operated on? If we're going to operate on them, do we need to do an open reduction, or can we do a closed reduction and then percutaneous fixation with K-wires? As you can see in that bottom image on the left. what kind of surgery are we going to offer the patient? If we're going to do an open reduction, are we going to fuse them? Are we going to bridge them? Are we going to do a fusion rather than joint preservation? These are all the issues that hopefully the people in the audience are thinking about, and hopefully we're going to have some answers to those questions by the end of the talk. Although I would just like to qualify that by saying there is no black and white. So, should we operate on or not? Well, for the last 30 years, we've always believed that there's no that surgical intervention for Lisfrancs is better than treating them conservatively. And people talk about undisplaced injuries and minimally displaced injuries, but these two papers, which were only published last year, but they look at what happens if we have that doubt in our mind and we treat people conservatively. Well, patients don't do well. So x-rays which look like they're minimally displaced, by 18 days, over half of them have displaced and they've then need to have surgery. The Ren paper is in the Chinese Journal of Traumatology, and again they looked at surgical treatments but compared them with conservative measures as well as percutaneous fixation. Basically they said that open surgery was gave a much better result than treating people conservatively. So that is something that I think we shouldn't need to think about, whether the minimally displaced fracture can be treated conservatively. The answer is no. Let's ask you a question though. What about close reduction? So we're going to put this poll out to you. Is close reduction as accurate as open reduction for getting that second tarsal metatarsal joint back where it should be? So people have been doing this for a long, long time, and there's still some people who feel that it's reliable and safe in their hands. And there are other people who think that it's not a good idea, and this is one of those surgical techniques which needs to be stopped. So we've got half of the audience have answered so far, and most people seem to be going for the second answer, that they feel like there's significantly poorer results. But we do have one person out on their own who feels that it can be treated with closed reduction. So I think most people have voted now. Have you got any particularly strong feelings on this, Raheel?
Yes, this is absolutely one of those gospel truths. You've got to open these fractures, get them reduced, bang on, and get them fixed. There's no room for percutaneous fixation in Lisfranc fractures. A lot of us are minimal invasive surgeons, arthroscopic, percutaneous, but there's certain fracture patterns you do not want to mess with, and Lisfranc is one of those. So I go with the vast majority of the audience here. It's interesting because recently we had a discussion in a foot and ankle forum, in the British foot and ankle forum group, where there was a exactly similar kind of case presented. A young patient had come in the middle of the night, was taken to the OR because there was a fairly displaced Lisfranc, and the registrar had pinned it. They'd done a reasonable job for their level, but there was a big discussion as to why this was left to a junior in the middle of the night. And the flip side was that the non-foot and ankle surgeons would do this as well. But then that's to do with education. You've got to educate your colleagues that there is absolutely no room for messing up, because your first time is your best time. If you can't fix it, jack it out with a spanning X-fix and leave it rather than going in and trying to mess around with these fractures percutaneously.
That's absolutely right. And what's interesting is that sometimes I've seen people try to reduce things percutaneously, and even though it may look very nice on their image intensifier views, when I've gone in and done an open approach, found that actually the image intensifier films, because they're poor quality imaging, they don't actually show that there is still malalignment. And so even though we use some form of imaging, it may not be reliable because the resolution isn't good, and that's why you need to perform an open reduction. And the evidence is there. So if you do a closed reduction, then a third of them will be actually fine, but 2/3 of them will be unacceptable. Whereas if you do an open reduction, you may still get a bit of slippage, but it's very few. So, and they've looked at this series of patients, and every patient who had displacement, had been treated with closed reduction and KY. So this is something that really should be consigned to history. We shouldn't be seeing X-rays like this anymore.
But it's unfortunate that we continue to see these problems.
Yeah, I mean that's from my own hospital. So yeah, we haven't educated everybody yet. So the next question is, what about extra-articular fractures? And the interesting thing for me is that there are no outcome studies in literature for extra-articular fractures. But I think that what we need to do is analyze what kind of injury this is, because if it's extra-articular, these are metatarsal fractures. They're bony injuries, but the joints that we're worried about are the Lisfranc joints, the tarsometatarsal joints. They're actually still intact because they're all held together by the soft tissues. There's the capsular attachments reinforced, and so all the soft tissues are still intact, but it's where you've got a junction between a fixed segment and a mobile segment, just at the metaphysodaphyseal junction. That's where these extra-articular fractures have occurred. And because they're not affecting the tarsometatarsal joint, I would say these are not actually technically Lisfranc injuries, even though the mechanism may be the same. And because it's essentially, it's a bony fracture, which you would expect to heal up if you manage them conservatively, that's what I would do. So if I have a patient whose CT demonstrates that their fractures are all entirely extra-articular, I would keep them non-weight bearing for 6 weeks or heel weight bearing, and then after that, hopefully on their x-rays, we'd see that the fractures had healed up and they're then stable again and able to go back to normal footwear. But it's interesting that there's nothing in literature really about this.
So Amer, we're getting a few questions coming through. So we'll let you finish off your evidence for these various decision-making algorithms, and then we'll pose these questions to you.
Sure. So next question is, should we be using transarticular screws or should we be using bridging?
Bridging.
And bridging plates. So
absolutely,
bridging plates or staples are what I normally use. And fortunately, someone very recently, just in June, did a systematic review. There was another good review last year as well. And they looked at all the evidence. And unfortunately, there isn't a good prospective randomized controlled trial. There's only retrospective studies and one prospective cohort study. And what they found was that the AOFAS scores were better with bridge plating compared to a screw if your aim is to fix in situ. And the mechanics are that the bridge plating and the screw give you similar stability. If you look at removal of metalwork, bridge plating, unfortunately, has a high complication with lots of metalwork needing to be removed. But if you take the removal of metalwork out of the equation, actually the reoperation rate for post-traumatic arthritis is the same between sort of screws and bridging. So you're not really losing anything. In my mind, I'm wondering, these transarticular screws, they're causing damage to the joint. Now, if it was the wrist or, in fact, any other joint in the body, you'd never put a screw across the joint because you're just damaging the articular surface. And so I wonder, well, one of the reasons that transarticular screws may do well is not because they are giving stability, but they're actually almost like causing a functional fusion of the joint, and that may be giving it a better result than you might expect.
You're absolutely right, because there is a paper which biomechanical analysis which has shown that the diameter of your screw in that small joint going through takes out about 10% of the joint's surface area. Now, the thermonecrosis that's caused is far greater. So you're actually, in effect, destroying that entire joint by passing a screw. Well, a lot of that joint by passing a screw through that. So it doesn't make sense putting screws, which isn't to say we don't want you to go away with the message that don't ever use screws, but there are better and more elegant ways now of fixing, and bridge plating has proven to be a better way of fixing these fractures if we decide to fix them. And
you need to adapt your practice with time. So that X-ray on the left, regrettably, that's an X-ray that of an operation that I did when I was in my first year as consultant, because screws were the way that I was trained. But because of the evidence, we've all had to look at our practice and say, actually, the way that I was trained probably wasn't ideal, and there are other ways of doing things. And you've got to develop yourself and develop your practice to take in the evidence and say, well, actually, what I did before wasn't optimal. I need to change to give a better result for my patient. So the big question, fix or fuse? So what I'd like everybody in the audience to do is to have a look at this particular injury and tell me, what would you prefer to do? Would you prefer to fix? Obviously the joints are displaced, and are you going to bridge them, and or use a screw to hold the joint, or are you going to say, I'm going to fuse these joints primarily? And it's perhaps not a fair question, because you could actually choose a bit of both. It's obviously a difficult question, because we've still got a lot of the audience who haven't voted. We'll give you a little bit longer.
What would you do, Amer? Would you fix or would you fuse?
Well, I know what's on the next slide, so I'll tell you in a minute.
So it's interesting. The majority seems to be going with fixing.
Yeah. Okay, so let's look at the evidence. So there are studies which have compared fusion and bridge plating. Now, they're not fantastic studies because they don't have a vast number of patients. And at the moment, there is actually a prospective randomized controlled trial to try to give us definitive and sort of more scientific information. But looking at this retrospective information, there's Carl et al. From 2017, and basically what they found was that the FAS score was better in arthrodesis than non-fusion. My only criticism of that is that 94 and 88, although they're significantly different, they're both pretty good. I think I'd be happy if my patients had if it's evidence, it's evidence. We've got to go with evidence. So if it's statistically significant, no matter how small the difference, it's statistically significant. Correct? I think everything has to be taken in context. So that's one small piece of evidence. Then another a little bit bigger study, they actually found that the difference was much more marked than the first study. So it might just be the statistics from the first study. It's actually underrepresenting the difference between the groups. And this is why you have to be you need to look at these studies and don't take one study as being proof of enough to change your practice. You do need to look at a wide range of them. But joined together, it does suggest that fusion is giving better results. And another paper from Yamin et al. From last year, much bigger series, 269 patients, and their p-value is 0.01, that they have a better functional recovery from arthrodesis. And there's another study by Albright et al. It's a bit difficult to see in the bottom corner. They looked at the quality analysis of life years following fusion and fixation, and they basically said that fusion seems to give more quality of life years than the fixation by bridge plating.
So it's a no-brainer, isn't it? You want to fuse.
You know what?
If there is there is even a hint of comminution, fuse it, Amer.
I think there are lots of factors that we need to take into account, and fusion is going to be attractive for some patients who want a reliable result and want to get back to work as soon as possible and want to get back to weight bearing. But there are some downsides. So if you remember, we talked about the mechanics. The rays need to have some mobility because they give function to the foot because of the longitudinal arches. So it's not a black and white issue where you can say for every patient we should be choosing fusion over bridge plating. I think it's a lot more complicated than that, and unfortunately it's become a very polarized subject, but there is a lot of grey area in between because of which patients might benefit from bridge plating.
So
you're going to ask me a question. I'm
going to counter you there. A lot of the evidence, because we've had a few questions about this as well. What about athletes? And there's another query that why is there so much controversy? I know we have lots of options in orthopedics, but why don't we have more simplicity in the Lisfranc algorithm? A lot of the evidence more recently seems to be pointing us in that direction of simplicity. It says if you have a patient, even a fairly young active patient, fusion seems to do the trick. Because your point about the amount of mobility required is in the fourth and fifth in the lateral column, because there is biomechanical evidence which says that the amount of sagittal movement in the medial column is about 2 to 4 millimeters, and in the middle columm is about 2 millimeters. So we're not talking massive amounts of movement. So why not just go ahead and fuse these?
Certainly, I think I don't agree with that. I think that certainly for the middle column. Yeah, for me, it's a no-brainer that for the middle column, if you've got comminution, it's a good idea to fuse them. But there are, arguments for trying to maintain some mobility, and I'm going to talk about that a little bit now. Again, the studies that are in the literature, there's a lot of heterogeneity because they're mixing old patients and young patients, and they're mixing comminuted and ligamentous. So actually what we need is better quality scientific studies to be able to elucidate what is required for each situation. Unfortunately, we don't actually have that. What we have are studies which are taking all comers, and I think that's what results in still some controversy in this area. Now, again, if you looked at the literature for lateral column fusion, that's not something that is advocated by anybody. So if you go through the last 30 years of literature, it's fairly agreed that if you have a lateral column injury, it should not be fused. Is that something you'd agree with, Raheel? Sorry, I've lost you. Sorry,
can you hear me now?
I lost your sound there.
Can you hear me now? Yeah, sorry. Lateral column, if you're considering anything, it's an excision arthroplasty, which is basically excise part of that joint and just put you extend the tendon into it as a spacer. Fixing that lateral column or fusing it is inviting. Yes, so totally agree with that.
Right. Well, this is the strange thing, because if you look at the literature, the results of fusing the lateral column, according to several studies, are that it seems to produce much greater improvements in the AOFAS score. But it's interesting also that even the authors who have demonstrated that, their conclusions are that they still would not recommend fusion because they think that the loss of mobility in the lateral column is going to cause the patients to lose that functionality. And so they would still go for an interposition arthroplasty, as you have advocated as well. But this is one of the difficulties of looking at the evidence out of context, because if you look at it in a black and white fashion, that's exactly what it suggests, that fusing the lateral column is a good thing to do. But I don't think there's any single author who would advocate that they would do that in practice. Although I've managed to find an X-ray of somebody who has fused the lateral column from one of these papers. Ligamentous injuries. We had a poll earlier on, and everyone I think everyone agreed that ligamentous injuries do have a poorer prognosis. And I think that we need to think about this in terms of the period of non-weight bearing. So Lai et al. In 2006, that's Lai and I think Kurtze, agreed that arthrodesis was just far better for ligamentous injuries compared to bridging them. And the same for Quo et al. In the JBS in 2000. But another author from Foot and Ankle International in 2015 said that actually there was no difference.
I like the way you say another author. That's Ali Abbasian.
Sorry, he's from London. Sorry,
guys, yeah.
So he says that there's no difference if you have the patient having a longer period of non-weight bearing after their bridge plating. So why would that be? Well, I'm going to talk about that in a while. It's on another one of my slides. So the things that we need to think about are, various factors. So I still think that treating Lisfranc injuries isn't a black and white issue. We do need to think about different factors, both in terms of the injury and the patient, and what we find on the investigations.
So I'm going to ask you a couple of questions that the audience has posed here before we carry on.
Sure.
I know we're not too far away from the surgical treatment. Level of activity, athletes, do they do well with fixation versus fusion? Because what are your thoughts?
If you have an athlete, if they are appropriately treated with the right amount of non-weight bearing, then they can do equally well from having bridge plating compared to fusion. I think that's what Abessian's paper demonstrated. And I'm going to talk about that in the next slide. And this is the key, and this is something that we've known for a very long time. If you have a ligament injury, the ligament is not going to grow back. Histologically, there is no continuity of that ligament in 3 months later. What you're relying on is the granulation tissue, the scar tissue, to provide the same function as that ligament. And Levinson studied soft tissue tensile strength, and it was always thought that there were different ways that the soft tissues could heal, and that if there was with early movement, they would perform one way, and late movement they perform another way. But what he demonstrated was that the tensile strength increases in a sort of on the sigmoid curve, so that you do get some rapid improvements in tensile strength up to 6 weeks, but actually your maximum tensile strength is only achieved when you get to 12 weeks. And even that maximum tensile strength is only 80% of the normal tissue tensile strength. So if you are getting your patient to weight bear early with bridge plating, your soft tissues haven't matured, and there's a risk then that there's going to be abnormal amounts of mobility. And I think what the FAI paper from 2015 demonstrated was that if you wait until 12 weeks, actually you get the maximum amount of soft tissue tensile strength, they're more likely to do well. And that will reverse the advantage from the studies that show that fusion is better than bridge plating alone. And it's a similar argument for the syndesmosis. Some people will weight bear the patients at 6 weeks, but traditionally we've always been told 10 weeks. And the reason for that is, again, because the soft tissues need 10, 12 weeks to mature and gain their maximum tensile strength. And unfortunately, in the studies in the literature, this isn't accounted for. So we need to actually differentiate how long people are keeping the patients non-weight bearing. And 3 months just seems like an awfully long time, but actually it's necessary. If you're going to bridge plate, you need to keep non-weight bearing for 3 months. And there's some patients who may feel that, well, I'm not prepared to wait that long, and they probably can weight bear if they have a fusion and at 6 weeks they'll be able to weight bear because they've got bony union, which is a different kettle of fish compared to soft tissues. So we've broken this down into an algorithm, and unfortunately it is very complicated, and I've not given you a black and white algorithm because there are still choices to be made, and those choices really depend on all of those other factors, the patient's choice as well. So if you've got a ligamentous injury, if it's displaced, you have to do something about it, and that could be either by bridging them or fusing them, depending on the patient choice and the function that you're trying to get out of the patient, and whether they're capable of waiting for 3 months. If they're undisplaced, if I'm convinced they've got a ligamentous injury, I'll do stress x-rays, and if they displace with stress x-rays, then they'll go on to have fixation. If they pass stress x-rays, that basically means that they've probably had a sprain, and we can treat them conservatively, give them a couple of weeks, and then get them walking in a boot. If they have a bony injury, if it's entirely extra-articular, then you can manage them conservatively. If they're intra-articular, if you've got just a marginal fracture, so you've just got a little avulsion off one side and it's not a large proportion of the joint surface, then you can still think about the alternatives of bridge plating or fusion, depending on what the patient wants. But if it's comminuted, then really there's probably not much point in trying to fix them with a bridge plate. What you need to do is to fuse them if it's the first, second and third ray, and if it's the fourth and fifth ray, then, as you said, Raheel, an excision arthroplasty is probably the best way to go. So that's a summary, really, of the decision making, but it's not still a black and white issue on the basis of the evidence that we have. And there are lots of other factors that you need to take into account. So having gone through the decision making, let's talk a little bit about the surgical techniques. So we do have a video for the surgical approach. For some reason I can't get it up at the moment.
You're looking for what? Sorry.
So we have to come. So we'll have to come out of the
okay,
presentation.
I'll share the video.
Yeah.
The approach to the tarsal joints is useful for approaching the joints for arthritis, for fusion, and for Lisfranc's fracture dislocations, which can be reduced. We're going to use the image intensifier to locate the line between the second and third metatarsals, and we're going to use the image intensifier with the McDonald's in a transverse position to accurately identify the surface anatomy of the joint itself. Similarly, over the lateral aspect of the foot, we're going to try to identify where the junction is between the fourth and fifth. We've made our incision over the junction between the second and the third, and we're careful to avoid branches of the superficial peroneal nerve. We identify the extensor hallux brevis tendon. This is an important landmark as the neurovascular bundle lies on the medial side of this. So if we can stay lateral to the extensor hallux brevis tendon in this line, We can go down to bone, stay on bone, and we should be safe and not damage the neurovascular bundle.
So I think that's the end of the movie. You can see that we can perform some dissection to strip off the soft tissues and see the joint surface and get an absolutely anatomical reduction. So that's the surgical approach. And a lot of people do tend to go between the first and the second, but that's risking damaging the neurovascular bundle. And it's actually probably better to go between the second and third, find the EHB tendon and use that to protect your neurovascular bundle. It's actually quite easy to find because there's only one muscle belly in the foot in that area, going towards the big toe. And what you can do is, once you found the tendon, pull on the tendon and you'll see the toe moving, so you know that it's the correct tendon, the EHB. So that's the approach. Now let's talk about screw fixation. We've already talked about that. Screw fixation. So what we're going to do is, if you have a look at the metatarsal, what you want ideally is for your screw to be as close to the axis down the metatarsal and the cuneiform as possible. So what we're going to do is cut a wedge out of the metatarsal, and there's the wedge cut out, and that gives you a better angle for putting your screw in. But if you're going to do this, I wouldn't do this as a temporary fixation. I would use this as a means of fusing the joint. So I trim out the joint surface as well and get cancellous bone exposed, break down the subchondral plate, and then after that you can put your screw in and lag those two surfaces together to generate your fusion. That's the screw fixation technique. Bridge plating, well, you know, everyone knows how to put a plate on. You can see some little, in the bottom left-hand corner, you can see these little T-plates. The picture at the top is quite a nice device. This is a striker plate. It's sort of in a pie shape, and it gives you good access, and you can contour that to sit over the cuneiforms. And as well as fixation, if you want to fuse, you can actually use the screws in an oblique way to compress the tarsometatarsal joints together. The tightrope technique, I use this quite a lot. So essentially, I've got the second metatarsal reduced. A lot of people who use tightropes will start off in the medial cuneiform, and they'll aim towards the second metatarsal, but actually it gives you a much smaller area to aim for, and it's much easier to go from distal to proximal. So I start off in the second metatarsal at the base. I find that bare area, which is non-articular, and then I pass it into the medial cuneiform and out of the skin. And then once I've got the guide wire in, we can over drill it. Again, you know, it's entirely extra-articular, so you're not going to cause any arthritis. And then you can pass the tightrope through, and you can really tighten up the tightrope a lot, and that will snug down the second metatarsal. But usually I use K-wires to hold it in position while I'm doing that. And then in order to secure it from that sort of temporary fixation as well, I would use memory staples, which will hold everything in their anatomical position. And you know, this is just a question of practice. Once you've done it once or twice, you get the hang of how easy it is to do, and it's less than 5 minutes. And then there's K-wiring, and I'm sure everybody in the audience has put in a K-wire. We'd only really use it for the lateral rays in order to secure them so that they can't drift laterally again. And if the lateral rays can't move laterally, then it will also support and buttress your second and third rays, especially if you're trying to fuse them. So those are all the surgical techniques that I think are required. And you know, I think that if you offer the patient options and you can identify their own circumstances, you can work out which route down this algorithm they're going to need to go. So that's really all that I've got to say on the subject. Before I finish, I'm just going to take the opportunity to talk about the OrthoCycle charity. So this is a charity that we run. We recycle medical appliances for less developed countries. So if your hospital is going to throw away any medical appliances or surgical equipment, then please let us know, because we'd like to take it to low and middle income countries, and even orthotics, we're recycling as well. So Raheel, are there any questions in the chat that we haven't answered yet that we can go back to? So I've lost you. I've lost your audio.
Decision-making algorithm and the evidence base for Lisfranc. As you rightly put it, there's no right or wrong, there's no black or white. But top 3 tips before we go into the questions and one final case we're going to discuss. It appears from what you've shown in the evidence that fusions actually work surprisingly well. So we shouldn't shy away from fusions because they've got advantages. 1, you can weight bear your patients much quicker. 2, return to activity seems to be good because AOFAS scores improved with all these compared to fixation. And 3, I'm not sure, I missed that part in your presentation, but the removal of metalwork seems to be far less with fusions compared to fixation, correct?
I think it's not so much the fusion versus fixation, it's actually the devices that are being used. So bridge plating, unfortunately, the plates themselves do seem to cause more problems with prominence of metalwork when all the swelling's gone down. And it's difficult to actually iron that out, because it may be that the screw fixation is better in that respect because there's nothing prominent. But it's not something that's eminently clear in the literature as to why that is.
Mm-hmm. Because I've read someplace that in a more than one paper that the percentage of metalwork removal seems to be close to 70% when we fix, no matter what implant we use, compared to fusion. Because I think once they're fused, it doesn't really matter if that, because they're quite pain-free. That's the message that seems to be coming through in some of the papers. Okay, Amer, we're just going to dive into a couple of questions from the audience because we've had a fair few, and then we'll discuss one final case. So,
someone's asked about the type of the classification.
Yeah, I was just going to come to that. So, what about the type of classification? Is it classification dependent? I suspect you're talking about the treatment option.
Unfortunately, there are very few classifications in orthopedics which are useful because they then tell you about the prognosis. I think, in the periprosthetic fractures of the hip, that's quite useful. That's the Toronto classification, isn't it? But in this situation, the classification really doesn't help you very much. It doesn't tell you what you need to do, because it's just really describing the nature of the injury, which you can see for yourself. And it's all those other factors about how much comminution there is, what the patient's social circumstances are like. All these things are going to influence your decision about treatment, but the classification, unfortunately, is not. So it's a historic thing. We like to talk about classifications for communication, but actually it's not very helpful.
Okay. One more question which we haven't answered is, if your injury is stable, when will you start weight bearing? I think you answered that in the talk, as the question was posed a little earlier. 2 weeks, correct? It's a sprain.
That's right. 2 weeks. And that's actually, I think that is actually Myerson's paper.
Protected weight bearing. Thank you.
Yes.
Yes. Okay. Great. So please feel free to post any further questions you have. We're going to dive into one final case before we finish off. So here is a 21-year-old who was on a trampoline and fell off trampoline and can't bear weight now with a swollen foot. Okay, so as we can see on that X-ray, sorry, I think we've discussed this case.
But we've done this case before.
It's
case number 1.
Okay,
so
I apologize.
We've done the wrong way around.
So here is a 23-year-old man involved in a road traffic accident, and he can't bear weight. I think you've shown us one of these X-rays in your talk. Foot's grossly swollen with little pain on passive movement. Okay, so your medial column there appears to be completely knackered.
Yeah. Yes. So there. Yeah. The first question we've got to ask is, what are we going to do? So we said he's got a swollen foot already.
Yeah.
We mentioned it earlier on. I think you said that you talked about external fixation. So should we get a CT scan first and then you put an external fixator, or should we put the external fixator on first and then get a CT scan? Or should we not bother with the CT scan, put an X-fix, and then when the swelling's gone down, we can go in and internally fix it? Because clearly the the medial cuneiform and the first metatarsal, they're nowhere near each other. Absolutely. So something has to be done. It's not going to be conservative. Do we need to just bite the bullet and go in for internal fixation?
So that's a tricky one because it's quite swollen. There's a lot of disruption of soft tissues there, and that medial column is completely trashed. So in the ankle, we've got this dictum or an appeal-on: span, scan, plan. Would you go with that? The vast majority of the audience seems to suggest yes. You want to span it, you want to scan it, in that order.
I think that you can't go wrong if you do that. No one will criticise you if you do that. Now, that's not what happened in this case, but it's So
okay, so we're all in
yeah. So I think everyone
X-fix first and then scan. Although there's a fair split in the audience between CT scan and then X-fix. So do you want to explain to us why you'd prefer spanning with an X-fix and then scanning as opposed to scanning and then spanning, Amer?
Okay, so the point of putting the X-fix on first is that it will give you some realignment, and by giving that realignment, it will actually aid you in your planning for surgery. And if you get a CT scan first, the worry that you might have is that if everything's all over the place, it doesn't actually tell you how you're going to be able to realign everything, how you're going to fit everything together. But if you put the external fixator on first, it might actually give you some ligament ataxis, it might realign everything, and it might make it more clear how you're going to be able to perform your surgery. But, I think either of those, I think what's important is that you're going to have a CT scan so that you can understand the injury better. So I think either of those two answers I'd be satisfied with. Okay.
So let's see what happens.
And this is the CT scan that's been done. And that's been done before he's had the X-fix put on. But although, I'm an advocate for putting the X-fix on first, what's really interesting about this is that when the X-fix went on, yes, it has realigned everything, but you might be fooled into underestimating that injury on the basis of the X-ray after the X-fix has been put on. And even if we go back to the initial picture, you can't actually tell on that image that the medial cuneiform is completely subluxed out. And it's the CT actually demonstrates that really clearly, that the medial cuneiform has been plantar displaced. So following that CT, they've had an X-fix put on. This was put on by a Sudanese doctor who's very, very capable, and it's a nice configuration. It's a box configuration with a denim pin through the calcaneus, and then some shunt pins through the first and the fifth ray. So it makes a nice sort of square configuration, and then you can join the two together over the top anteriorly with some more connecting bars, and that gives it a very stable configuration. Now, after 3 days, patient's still swollen, and bizarrely, from that beautiful position with the external fixator on, the X-fix has been removed, and someone's performed close reduction and K-wire fixation. So what do you think about that, Raheel?
I'm quite surprised, because you'd rather leave it in that X-fix than cause more problems by taking that X-fix out and putting a couple of wires in there, because clearly those wires are actually making things worse. You've got, looking at that X-ray, the sagittal view, you've got plantar flexion of that first metatarsal. It's plantar displaced. There's a bit of distraction in the first tarsometatarsal joint of the AP. There's clear widening in between your bases of your first and second metatarsal. You can drive a truck through that space. So from a reasonably well-aligned foot in an X-fix, we've gone to a very poorly aligned foot with two small K-wires. So I don't understand the reasoning behind that decision.
But it's basically the old school way of doing it, isn't it? The closed reduction and percutaneous fixation.
So again, this case really highlights why, if you go away with one take-home message, don't use K-wires in these injuries. You'd rather put an X-fix and let it gum up and heal up than mess around with K-wires, because they just won't work. Okay, so what do we do next?
Right, so post-op instructions say leave for 6 weeks. I think
So
we've decided
that,
we're not really happy with that, are we?
Reduction is not perfect. Return to OR to change K-wires to what? Another set of K-wires?
If it didn't work the first time.
Reduction is not perfect. So CT scan and plan internal fixation. Reduction is not perfect. This doesn't matter. Leave it alone. Okay.
And from what we've discussed, we know that actually, if the reduction is not perfect, it does matter.
Absolutely.
So, so we're going to discount that.
So I think the vast majority of the audience have got this right. 80% say CT scan and then plan internal fixation. So we agree. So let's sort of talk through the principles of that. So let's go back to that X-ray there. Let's put all that we've learned from you into practice. The medial column is unstable. Your second ray or third ray is possibly unstable. Second ray on that CT scan top picture shows there's dorsal subluxation. So how would you approach this? Would you go with you've got to stabilize your medial column and then build your middle column onto it, correct?
Yes. Yeah. So, I mean, this is, well, I mean, I think we're going to have a poll about this, don't we?
Okay. So the CT scan shows malreduction, displaced second tarsometatarsal joint, displaced first tarsometatarsal joint, opening up of the navicular cuneiform joint. Is this still a Lisfranc injury? Well, and for all practical purposes, yes. Let's see what approach we need. Let's share this with our audience. So we're going to go, one option is to go dorsal to reduce the second TMT joint. The other option is to go medial approach to reduce your first tarsometatarsal and navicular cuneiform joint. KY the lateral TMTs, if unstable, all of the above. Okay. Let's give the audience a moment. So I think it's safe to say the vast majority are agreeing with us, seem to be in agreement that it's all of the above might be required. Now the question is, what steps would you follow? Would you open medially, reduce your first TMT joint, and then move laterally to the second ray? How would you approach this?
I think what I would do is I'd say that the middle column, the second metatarsal and the intermediate cuneiform, that's what we're going to base everything on. So we want to reduce that first of all, and then reduce the medial column onto that, and reduce the lateral column onto that as well. But you know, we know that the cuneiforms and the metatarsals, the second and third, line up very well congruently with the metatarsals with the respective cuneiforms. And if we get that right, then we know that if we just bolt everything onto that, then hopefully it will give us a nice anatomical result. Okay. So I agree. We probably need to do all of those approaches. First, we need to reduce the second. We need to reduce that cuneiform which has been subluxed, and stabilize it. And it's going. It's two different joints which that cuneiform's subluxed out of. So,
okay, so I think the vast majority have got that right. So final couple of slides before we wrap up. How do you avoid the deep peroneal nerve and dorsalis pedis? So carefully dissect out the nerve and artery before doing anything else. Use the extensor hallucis longus to protect the artery. Use the extensor hallucis brevis to protect the artery. Let's just sacrifice that artery because there are plenty of good collaterals. I know what I'd be doing. Okay, so I think it's good. A lot of us have been paying attention to your talk, Amer, because the vast majority are going with using the extensor hallucis brevis. So you find the lateral edge of the extensor hallucis brevis and then sweep the whole thing across medially, and your neurovascular bundle, as you said, comes across with the EHB there.
Perhaps a few people came to the talk late and they missed that bit, but if you want to watch the recording, you can watch the recording on the OrthoNinja channel or on YouTube. But if you have answers that you want to dissect out the nerve and artery or use the EHL, please watch the recording so you can get all the information that we might have presented and you've missed.
So it's a fantastic looking x-ray there. You've bridged your navicular cuneiform and first tarsometatarsal joint, and you've put a tightrope across the base of the second. How did that patient do? Well,
yes, actually, the plate needs to come out after 3 months, but you've got to accept that there's going to be some stiffness, and he's a very young patient, and so he's been given a chance to maintain mobility at the first TMT joint. But if he develops pain, and that's a very real risk because of degenerative change, then he may have to have a Lapidus fusion.
Excellent. All right, I think that's the end of our session. We'll give a moment for the audience if they've got any questions. If not, that was a fantastic whirlwind through Lisfranc and the evidence base. I've learned tons. I'm going to be using fusion as a much. I'm going to be having a much lower threshold to fuse my Lisfrancs now.
Yeah.
Any final thoughts?
Shall we look at some of the questions? So Mazen has got a question. He's looking at a paper from Gurul et al. With a simplified treatment algorithm. I've read that as well, and I think that there's a lot more complexity to these injuries, and having a very simplified treatment algorithm, especially in your just fuse or fix, isn't the right way to do it. I think that you need to consider all the other factors as well, and hopefully that will give our patients sort of a better result in the long term. But there is an ongoing trial, and hopefully that ongoing trial, which is multi-center, multinational, is going to give us better quality information so that we can really fine-tune a treatment algorithm.
Okay, final question from Christian. Have you ever noticed any osteolysis after 3 months from a tightrope? That's a great question.
I have seen osteolysis after a tightrope, but in a coracoclavicular ligament reconstruction in the shoulder, but I haven't seen it from using a tightrope in the ankle or for Lisfranc injuries. And I'm not sure why. Maybe it's because we're not looking, but often with Lisfranc injuries, I'll be following the patient up for sort of 9-12 months afterwards, but that's not something that I've noticed.
Okay, excellent. Thank you, Amer. On that note, just a quick heads up, same time next week, we're going to be doing calcaneal fractures, and that's one surgery which Amer actually does percutaneously and is a great proponent of that. I learned my percutaneous fixations from Amer on calcaneal fractures, so I'm looking forward to that one, where we're going to be discussing all things calcaneal. Yeah, Amer?
That's great.
Thank you very much.
Yeah, thanks.
Hope everyone's enjoyed this session. Thanks, everyone. See you next week.
Right. Good night.
Good night.